to talk. All right. Thank you very much for joining this happy Thanksgiving week. And today we're going to talk about minute ventilation and auto PEEP. Let's see what that's all about by using our simulators we've worked through before. And also appreciating that I have to work hard with the simulator. The simulator is known as X-Lung. It is a fantastic simulator that helps us to understand the dynamics of lung ventilation. I don't understand all the ins and outs of the simulator, but I do feel that it is helpful to use it to basically look at some concepts. So what we want to remind ourselves, and we talk about 4 issues in mechanical ventilation, is the patient appropriately oxygenated. Now, we talked about that last week when we talked about PEEP and mean airway pressure. We may revisit again in a broader stroke. Are their lungs compliant? We talked about that last week and the week before, looking at peak pressure and peak plateau pressure. And are we protecting their lungs? And is the patient removing CO2? That's really part and parcel of the same thing. But our focus today is really about CO2 removal. So always really important to remember that vent settings that we use to improve ventilation, there really are 3. Okay, the first one, of course, is respiratory rate. And typically, we don't ever want to set on a standard ventilation. That means on assist control or SIMV, whether it's pressure or volume targeted, we really don't want to have the respiratory rate greater than 35 times a minute. Now, that's not going to hold true if we're using something like high frequency oscillation or airway pressure release ventilation. In those instances, patients will breathe more rapidly with very, very small breaths, like 1 to 1.5 mLs per kg, tiny, tiny breaths. So they're going to breathe much faster. But it is also really important for us to remember in standard ventilation, so that means assist control or SIMV with a set rate, either volume control or pressure control, anytime the rate is greater than about 30, what you start to see is a reduction in the time of exhalation, which means that you may actually trap gas in the lung, and that can promote something called auto PEEP. Now, sometimes we like auto PEEP. Sometimes we're trying to generate that, but it's important for you to know when you're trying to create that or when it is created by your method of ventilation, inappropriately created by your method of ventilation. So always really important. We also talk about tidal volume. Respiratory rate times tidal volume gives us minute ventilation. Typically, today's world, we like to set the tidal volume at 6 to 8 mLs per kg of predicted body weight. And you'll remember I've talked about predicted body weight before, that it's not really about how much the patient weighs. It is about their gender and their height, which determines the size of the thoracic cage. And remember, when you are breathing at higher tidal volumes, 8, 9, 10, you run the risk of overdistension of the alveoli and risk of volutrauma. Other ways that we can decrease PaCO2 is that we can actually reduce the metabolic rate. So we can control seizures, we can control muscle activity, seizure, of course, basic seizure methods. Controlling muscular activity, we may actually utilize aggressive sedation or a neuromuscular antagonist, or even a coma with pentobarb or phenobarb. Those are going to help us to control muscle activity and therefore production of CO2. And of course, making sure that you minimize the carbohydrate load that you are feeding your patient, because that carbohydrate load then ultimately turns into CO2. Being also aware when you're administering bicarbonate that once you give bicarb to neutralize the pH, that will, of course, dissociate into CO2. So everything, you have to think about what produces CO2 and then how we regulate the CO2. CO2 is produced at the cell and it's regulated by the lung. Now, there are going to be times that we might choose something called permissive hypercapnia. Now, just like choosing auto PEEP, wanting my alveoli not to collapse, so I create an auto PEEP situation like I might do with prolonged I to E ratio, inverse ratio, like I do with airway pressure release ventilation, like I do with high frequency oscillation. Very important to also remember that I chose auto PEEP. It wasn't inadvertent, just a happenstance because I failed to ventilate my patient appropriately. The same thing is going to be true of permissive hypercapnia. Sometimes, in order to protect the lung and to try to open the derecruited alveoli, we may choose an ultra-low tidal volume. And if we're not using a methodology that allows us to have a higher rate, we may actually say, I understand that in this situation, I'm going to allow my patient to retain CO2. That's preferable to an over-distension of the alveoli, which then, of course, will promote ARDS, and also is better than having a dangerously high respiratory rate, anything greater than 35. But permissive hypercapnia means that you will have a primary respiratory acidosis. Now, we don't really worry as much about respiratory acidosis as we do about metabolic acidosis, because in respiratory acidosis, you don't really have significant displacement of the depolarizing ion, potassium, and so you don't tend to see that the patient has refractory hypotension. Okay. I to E, very important. So when we talk about increasing inspiratory time, we're going to reduce the exhalation time. And so the proportional ratio, which normally for you and I is 1 to 4 for every breath we take. It's 1 part inspiration, 4 parts exhalation. It just depends on your respiratory cycle, how many seconds that is. But as we prolong inspiratory time, we're going to reduce the flow rate, deliver the gas into the lung much more slowly, but that can also lead to significant auto PEEP. And you may choose that auto PEEP, but remember that when that's endogenous auto PEEP, not external auto PEEP, when it's endogenous auto PEEP, the gas that's in the alveoli will be relatively CO2 rich, and there won't be time for exhalation. We talked before about peak inspiratory pressures. We always want to keep our peak inspiratory pressures, if possible, less than 40. The absolute max is 45 centimeters of water pressure. And one of the things that we can do, there are more than one, but one thing that we can do is when someone has a high peak inspiratory pressure, and that's not because they're coughing or chewing their tube or the tube's in the wrong place or they're combating the vent, they just have a high peak inspiratory pressure, we can reduce the tidal volume. We're going to take a look at that with the simulator. And then, of course, plateau pressures are looking at the pressure that is generated when your alveoli are distended with gas. The less alveoli you have, the higher the plateau pressure. So always really important for us to consider that when we talk about vent settings to improve to mechanical ventilation. To improve CO2 removal. So I always like to remind you about minute ventilation. That's respiratory rate times tidal volume, and that's usually around 6 to 10 liters per minute. You might tend to want that on a little bit higher side to help your patient regulate their CO2 more appropriately. So again, if you set your tidal volume at 8 mLs per kg ideal or predicted body weight, and their rate is 10 to 12 or maybe 14 or up to 16, what you're doing is you're always shooting for a minute ventilation. So when you go down on tidal volume, you will naturally have to go up on respiratory rate. And when you go down on respiratory rate, you will naturally have to go up a little bit on the tidal volume in order to try to maintain the liters per minute that you're breathing for the patient in order to help regulate and remove CO2. Normal arterial carbon dioxide, 35 to 45 millimeters of mercury, and tidal is 5 less on either side, 30 to 40. And these should always travel in the same direction. Now, what that means is if I'm hypoventilating, my PaCO2 is up and my end tidal CO2 is up. If I'm hyperventilating, my PaCO2 is down and my end tidal CO2 is down. When they don't travel together, that tends to be more of a perfusion problem. In other words, if end tidal CO2 is really low and arterial CO2 is really high, you should start to consider that you have an obstructive shock, maybe a pulmonary embolus, maybe compression of the pulmonary vessels with your method of ventilation. And then, of course, we'd like to see the pH in a range of normal. That maintains normal cellular homeostasis, electrolyte shifts, depolarization, vascular tone. So we always would like to see the pH in the range of normal. But remember that a respiratory acidosis doesn't affect vascular tone nearly as much as metabolic acidosis does. So let's take a look. I'm going to stop sharing here. I'm going to share again with my simulator. Okay, and let me move that simulator up so hopefully you can see it. And we're just going to look, this is actually the X lung, but I think this will be the right one for us. Okay, so let's take a look at that lung. And I want you to focus over here on minute ventilation, which is 7.61. That's gorgeous. Our patient is getting 500 cc's tidal volume. That's a little bit high, but maybe we've just intubated, and the rate is 14. So exhaled tidal volume. So very important, exhaled tidal volume is the amount of volume you're exhaling per minute. And then you multiply that times the respiratory rate. And this patient's breathing a little above the vent. As you can see, it's just a simulator. And we're close to 7 liters a minute in exhaled volume, 7 liters a minute in minute ventilation. And you can see the peak pressure is very nice. You always want that to be less than 40. Okay, so I'm feeling like my patient is breathing pretty fast. He's blowing off his CO2. So I'm going to reduce his respiratory rate. Now you'll see that his minute ventilation starts to drop, and it's going to take a second for that to occur. Okay, minute ventilation is going to start to drop, and you'll see that. And also the peak pressure goes down a little. Now I'm also going to go down on his tidal volume, and I'm doing this just to show you the effects of what occurs. Okay, so I always have to confirm. Okay, and now as I've gone down on his tidal volume and I went down on his respiratory rate, you can see that his CO2 is starting to climb up. His pH is now a little bit on the alkaline side. It's still normal. And my minute ventilation dropped. Okay, so I'm pretty happy with that. But if my patient actually starts to have, I'm not positive this will do what I want, but I think it will. So my patient starts to utilize more muscle and he is pulling hard. So what you're seeing here is dysynchronous breathing. That's dysynchronous breathing. Now that's a double hump. So what you see is the first hump and a second hump. And you see that here as well in the flow rate. That you're actually seeing that the patient gets a breath from the ventilator and then he pulls against the ventilator. You would typically also see that as a double hump here in the tidal volume. Now, what's going to happen is you might start to have some alarms. So you're going to come in the room, the patient looks agitated, you look at the monitor, you say, that looks really bad. And my patient is actually mobilizing a lot of CO2. Now, what that typically means to me is that I'm not flowing fast enough for my patient. I'm not flowing. Flow is the rate of speed at which I'm going to deliver the tidal volume. And normally it's 60 to 80. So I'm going to go up a bit on that tidal volume. Okay, on that, I'm not the tidal volume, on the flow rate. And I'm going to go down a little bit here on the respiratory rate. And let's see what happens. Okay. So, ooh, look at that. He's hardly moving any volume at all, 4.52. That's his tidal volume or his flow rate. And you can see that kind of goes up and down every time he gets a breath. You see that his minute ventilation goes up and down. So I didn't actually achieve what I had hoped to achieve with that situation. I'm going to go back. I wasn't sure what was going to happen. So let's just go back to a normal breathing pattern. I'm going to go back up to about 12 per minute. So I'm setting his respiratory rate. I'm going to confirm that. Okay. And he has some respiratory alkalosis. So I feel like his flow is going too fast. So I'm going to reduce that flow back down to 60. Now, if I'm the respiratory therapist at the bedside, I'm doing that all the time to try to make sure that we're breathing our patients appropriately. So you're going to see that he's going to start to retain a little bit more CO2 and his pH is going to start to come down. And you can see that his exhaled tidal volume is going up. So it's 4.8. Now, remember, this is a simulator. This isn't a real patient. So it's a little bit hard for me to mimic a real patient condition. But I wanted to show you how your therapist at the bedside will say, okay, so now look at our pH is coming down from 7.51 and his PCO2, which was down in the 20s, has now come up and he's looking really good right now. He has a kind of a low exhale tidal volume. Here's his exhale tidal volume. That was in mLs per kg. This is his normal exhale tidal volume, 6.53. And remember, normal exhale tidal volume is 6 to 10. Okay. Now, that means that I have a lot of room to go if my patient actually starts to retain CO2. So now I'm looking at the patient. I didn't even do anything to him. He's retaining CO2 and his pH has dropped. So what I'm going to do is I'm going to go up on his respiratory rate. And I'm probably also myself probably go up on his tidal volume just a little bit. Okay, so I'm going to breathe him just a tiny bit faster. Okay. And what you're going to start to see is that his CO2 will start coming down. It's going to take a bit, takes a minute, doesn't happen immediately. So if I'm at the bedside, what I'm going to expect to see is that his end tidal CO2 will start to actually start to come down. And I'm going to assume as end tidal CO2 comes down, that my arterial CO2 is going to normalize more effectively. So remember, in general, and that's why you can not always just rely on end tidal CO2, but in general, you're going to use end tidal CO2 to predict what your arterial CO2 is, as long as you've validated that. Remember that if you have obstructive shock, let's say you have a pulmonary embolus, or you're using a lot of PEEP and you're compressing those pulmonary vessels, your patient will have dysynchronous end tidal and PaCO2. But in general, when we talk about ventilation, not perfusion, ventilation, end tidal CO2 and PaCO2 travel in the same direction. So you can see we look a little bit better here. We might want to make him even look just a tad bit better. His minute ventilation is only 5.7. So I'm actually going to go up to 400. And I'm going to go up to a rate of 16. And again, your therapist is doing all of this, but it's important for us to appreciate what that actually means when we're talking about how we're looking and observing our patients. Now, you can see here, this pressure graph has changed a little bit, right? This looks a little bit better. Here's your tidal volume, here's your flow, and here's your pressure, okay? And you can see right here, my patient had a very significant double hump. That kind of concerns me that he's got a double hump. He's a little dysynchronous with my ventilator. Okay, so again, minute ventilation, V subset E, minute ventilation 6 to 10. Typically, we're going to adjust that with the tidal volume and the respiratory rate. We're also going to adjust the flow rate. And you can see once again that I have a nice peak inspiratory pressure. Now, let's just see what would happen. You would never do this ever, ever, ever. I just want to see what's going to happen when I go up on my tidal volume. So I'm going up just to show you that what's going to happen when I go up on that tidal volume is that over time, what you're going to see is that peak inspiratory pressure that went from 14 to 20, because I want you to see the effect of tidal volume on the peak inspiratory pressure. So went from 14 to 20 to 25, and it's going to continue to go up. Now, if this was in a real situation and you just had a standard tidal volume, 380, 400, 420, your high pressure alarm might start going off. One of the first things that we're going to consider after we rule out that there's a mucus plug, that the patient's biting a tube or is dysynchronous with the vent, or that the tube is in the wrong place, your therapist may reduce the tidal volume. Now, we made that happen because I went up on that tidal volume. I'm going to go back down to about 420 and keep them there. And you'll see that as I've done that, keeping an eye on that peak inspiratory pressure, also on the blood gases. Remember, we're not necessarily looking at the blood gas at the moment, but we will be looking at the end tidal CO2. And tidal CO2 went down, PaCO2 went down, peak pressure went up. But as I've adjusted my patient's tidal volume, what I'm going to see is that peak pressure goes down. And I'm going to see a return of the PaCO2 back to a relatively normal position, okay? So that's a really important thing. I can never change the rate of flow, which is how fast I'm delivering the volume, if my lungs are not compliant. And in general, I'm going to determine compliant lungs just from first pass if my peak inspiratory pressure is less than 20. That would mean your plateau pressure has to be less than 20. Okay, so that's always going to be a really important concept. We talked about peak pressure and plateau pressure last time we were together. Okay, so I'm going to stop sharing that and go back to my slides. All right, so just want to remind you what hypercapnia is and what it does. Obviously, hypercapnia means there's an excess CO2 in the blood, and that degree is tolerated not only based on the failure of homeostasis that occurs with CO2, but as CO2 displaces oxygen in the alveolus, you're going to see hypoxia as well. Now, typically, we talk about hypercapnia as moderate, which is 40 to 100, or severe, greater than 100. But our biggest concern with CO2 retention is as it relates to the central nervous system. And all of us can really appreciate that, right? The higher the CO2, the more vasodilated the cerebral vessels are, and the more cerebral blood flow increases. What that means is your intracranial pressure is going to increase. So when you have high CO2, your cerebral vessels dilate in order to try to, as a normal response, but also basically in an attempt to deliver more oxygen to the cerebral tissues, which are profoundly oxygen dependent. But that's going to cause an increase in intracranial pressure. Hence, 20 years ago, we used to say, blow off your CO2. But what happened is when we blew off too much CO2, the vessels constricted so much that oxygenated blood flow couldn't get through. And so that was always concerning. Now we basically say we want to keep our patients' CO2 around 33 to 35, if possible, if they've had a head injury or if they have increased intracranial pressure. Now, very, very important is that in effect of that CO2 on the intracellular pH, which actually changes the depolarization of the cerebral cells and their normal activity, and can indeed create what we call an inert gas narcotic effect. So we're not only going to look at CO2 in the blood, we're also looking at end tidal, and we're also understanding the effect of CO2 on the cerebral vault. Okay. So always important to remember, cerebral blood flow varies very significantly related to the PaCO2. And that's really, really important. For every millimeter mercury change in CO2, the blood flow changes 1 to 2 mils per 100 grams per minute. So what that means is as CO2 goes down, you increase your blood flow. And as CO2 goes up, you decrease your blood flow. So if your CO2 is up to 60 or 70, and that's acute, so it's not chronic, in which case you've actually compensated in multiple ways for that chronic CO2 retention. But if you've had an acute CO2 retention, that is so profoundly going to change your cerebral blood flow. So very, very important to remember that. And a lot of it depends on the alteration of the pH, which is in the interstitial fluid. That's why I would say in a very advanced neuro practice, you might hear them talking about microdialysis, where they're actually monitoring the cerebral spinal fluid at all times, looking at pH variability, which really tells you about the integrity of the cerebral tissues. All right, so now we just go from that to talking about permissive hypercapnia. Here's the problem. Permissive hypercapnia, which, by the way, doesn't mean I failed to ventilate you appropriately. It means I have chosen vent settings to allow you to retain more CO2 in order to protect your lung. It does appear that it's relatively safe, but not in patients who have head injury, not in patients who are hemodynamically unstable, and not in patients who have myocardial irritability and dysfunction. Also, if they have a high intrathoracic pressure, maybe they have pneumos, they have hemos, they have high intrathoracic pressure because of the kind of ventilatory support you're applying to those patients. It is not actually determined what level of CO2 is going to be detrimental. We're just not sure how detrimental that CO2 is. It's still not even clear how low a pH value you could have in your arterial blood. So I will tell you that depending on your population of patients, depending on your pulmonologist or your critical care doctors, will actually determine how they utilize permissive hypercapnia. Okay, so I think we already took a look at some permissive hypercapnia. but I'm going to stop sharing here. I'm going to hopefully go back to my X lung. Okay, so let's say, okay, let me put the patient into severe ARDS. Okay, and hopefully they're going to do what I want them to do. I checked them before, but you know, things always change. Look at how different the volume and the pressure is. Look how high that pressure is. So you can see his peak inspiratory pressure is really high. And let's just say you're working in a place where you don't really have the ability to do alternative forms of ventilatory support. Now, your patient is hypoxic now, and of course, that's going to be our main concern. But our focus here is what we want to do first and foremost is we want to protect the lung. So we're going to drop down to about 4 to 5 mLs per kilogram for this patient. Okay. We're probably going to also want to drop his respiratory rate. And by the way, guys, because his lungs are non-compliant, you saw that with that peak inspiratory pressure, you can't flow the gas any better. But what you can do is go up on his PEEP, which is what we're going to do to try to recruit his oxygenation. We talked about that last week. Okay, I'm okay that his CO2 is 50. I'm okay with that, and that he's a little bit acidotic. My biggest concern right now is, of course, he's only on 21%, so I'm going to put him up to 100%. Let me just put in 100. Whoops, 4,300, 3,100, no, 100, and confirm it. And meanwhile, he's just about ready to code. Now you'll see that his pressure now has come back a bit under control. His volume is low, his flow is low, but now because I've used a high PEEP, a high FiO2, a low tidal volume, okay, and I'm going to actually go up on his respiratory rate because I went down on his tidal volume. I want to blow off some of that CO2 because he's quite dangerously high. He's oxygenating a bit better. He's got a SAT that's almost acceptable. And what I have to do is, and he's not really doing what I want him to do, actually. Although he doesn't look that bad, except that his PaCO2 is extraordinarily high. So I'm having to be patient here because I just made some adjustments with his rate and his volume to try to get his CO2 down. And I have to also be concerned that perhaps the PEEP is limiting his outflow, but look at his oxygenation. Even though his P to F ratio is only 84, his SAT is 95%, and now I'm blowing his CO2 off. And at this point, I'm probably going to be okay with this. I've got a very low tidal volume at a high rate, and I might even reduce his flow just a little tiny bit down to 55 because I'm trying to protect his lung. And so what I'm going to expect to see is a bit more normalization. I can see he's oxygenating better. That's because I prolonged his I time. And his CO2 is 51 and 7.31. Now I look over here at the change in this visualization. I'm going to go up to here. And I'm showing you, this is his peak inspiratory pressure. Here's his plateau pressure. So here's his peak, here's his plateau. We're seeing that his peak is 42, his plateau is 29. And that's actually quite high. But what I want you to know is that what I'm really concerned about is plateau minus PEEP, which actually gives me something called drive pressure. Because when I apply PEEP, your plateau pressure is going to go up. That's what's going to happen. I've applied PEEP, that's distending pressure that's staying in your lungs. You can see that I've recruited this patient's lung. I'm doing beautifully. Now, this is a simulator, but by the way, sitting around for 2 or 3 or 4 days while people are kind of talking about what they're going to do for the patient. Meanwhile, the patient was hypercapnic and hypoxic. We have to be able to make rapid adjustments, not as rapid as I did. Obviously, that's quite concerning. Okay, but you can see I got him reoxygenated very quickly, and I helped him to regulate his CO2. His CO2 is a little bit high, but it's not really high. And if I'm worried about that, I could always give him some bicarbonate. But if I give bicarbonate, I'm going to have to increase his respiratory rate to help blow off his CO2. So that's our physio lung for now. Hopefully I was sharing that. I think I was. I hope I was. And let's go back to, oh, Nope, you couldn't see it. Okay, well, I'll go back in here and share that screen again and just show you what I've done with our patient, okay? So he has a peak pressure of 42, and that is a little bit concerning to me. But what I want to do when I'm looking at the peak pressure is I can go down on the tidal volume and I can go down on the flow. And his PaCO2 went up to 80. I've gotten it down to 49. I'm pretty happy with that. And his oxygenation, I put his PEEP up to 14, his FiO2 up to 100%, and he has pretty good oxygenation. I'm now going to go down on his PO2. I'm going to go down to 80, and I'm feeling like he'll probably do okay with that. I don't know. And over here, what you see is peak and plateau, and you're seeing that here. Here's his peak, here's his plateau. So this is just giving us plateau with every breath, even though that wouldn't be happening. We have to press the inspiratory hold button. Okay, well, what I'm seeing here is that his peak pressure is 42, but that's 42 minus the PEEP of 14. His plateau pressure is 29, but that's 29 minus the PEEP of 14. Now, plateau minus PEEP gives me what I call dry, or what others call drive pressure. And we'd like the drive pressure to be 15 or less. So although you might not be very happy with a PO2 of 81, he's sitting at 95%, his CO2 is 49, and his pH is 7.32. Now, what I'm going to do is I'm going to go back to normal intubation without much respiratory effort. And I'm going to go back up on his volume to 400 because I think we missed some of that, and down on his respiratory rate to 14. I want you to watch what happens to his peak pressures as I do that. And you can see the peak pressure drop significantly. Now, this is a nice, normal, compliant lung, and his peak pressure is 26. So that's fantastic. That's fantastic. And I'm going to increase his flow to about 65. And you can see your patient is extraordinarily well oxygenated. So I think I need to go down on his PEEP. And of course, I would never do it this quickly on a real patient. This is just a simulator because his PO2 is too high. It's washing out his nitrogen. And I'm going to go down on his FiO2 to probably about 65 just for now, because I want to see how he's going to respond. And so what you start to see is a lot of response over time. Let me just send a message. Teaching virtually. Okay, thank you so much, my friends. Always appreciate your patience. Okay, so now just take a look. I went up on the flow. I went up on the tidal volume, down on the respiratory rate. I'm looking pretty darn good. Now, you can see that his CO2 went up just a bit. Okay, so I'm going to just go up on his respiratory rate a bit. We'll see what happens in that point. Should not see a big change in his peak pressure, but you can see how beautiful his volume, flow, and pressure graphics are. Okay, so this patient's very well oxygenated. Again, we would come back and say, oh, we've already dropped our PEEP to 8. We can go down on the FiO2, and I'm going to go down to 45%. Okay, and confirm it. And you'll see over time that his oxygen comes down. So last week, we talked a lot about PEEP and mean airway pressure, and also just recognizing drive pressure, normal drive pressure, which should be less than 15. Now look at us now. We have a beautiful drive pressure at 6.82. Should always be less than 15. That's PEEP plateau minus PEEP. Some people like it, other people don't like it. The problem is when you measure a plateau or you measure a peak pressure, if you are not compensating in the number for the amount of PEEP you're giving, then you are falsely looking at your patient. So really important. Our patient looks pretty good right now. Okay, now I'm going to stop sharing. And thank you very much, Eugenia, for reminding me that I wasn't showing my screen. So hopefully I caught you up on that. Okay, so now we just talk very quickly about auto-PEEP. Auto-PEEP means that you are actually trapping gas in the lung. Now, when you trapped gas in the lung. That's trapped in the alveoli. The alveoli can overdistend, and that can actually cause an increase in the thoracic pressure. That can lead, of course, to significant trauma of the alveoli. It can cause a rupture of a bleb, a pneumothorax. And the patient, if he is trying to breathe, he's got to take a much larger than a normal pressure differential to start a breath. So this is really important. Now, I'm going to say something that, please, all my respiratory therapy colleagues, forgive me. I'm just going to say, when I am not the person that is determining that you have auto PEEP, what your auto PEEP is going to be is CO2 rich gas. If I am providing you with auto PEEP because I'm not allowing you to exhale, I'm actually going to hopefully generate a refreshed gas, more oxygenated gas. It is really important for us to look at auto PEEP. Now, I couldn't figure out, I tried to work it out with the simulator. I think I can show you a little bit of auto PEEP with the simulator, but prior to that, I just want you to know the only way that you look at this, so this is a scalar, it's flow over volume. That's a scalar, so we're not going to worry about this. When you're looking at your vent screen, you see gas flows in and then it flows out. And that exhalation should always come back to the zero baseline. Doesn't matter how much PEEP you have, it does not matter. The exhaled gas should always come back to the baseline. Now, that baseline is called the zero baseline, but if you're on 5 a PEEP or 8 a PEEP or 10 a PEEP, that's the new zero, and exhalation should always come back here. When you don't have enough time to exhale, you're going to trap gas. That gas will be CO2 rich gas. It will then lead to your patient having a retained CO2. So not only do we look at respiratory rate and tidal volume, therefore minute ventilation, but we're always going to look at whether or not our patient is exhaling the gas from his alveoli, or is he trapping. So that's what you're seeing here. This is auto PEEP. Okay, the PEEP that is dialed is 14. That's the PEEP that we were giving you, but he actually has an auto PEEP that's much higher. You're not seeing that number there. Unfortunately, this was the only picture that I could have. So now we're going to try to create it with our simulator. So now I'm going to go back and share my screen again with my simulator, and I'm going to try to show you as best I can auto PEEP. So you should be able to see this. I'm going to do it with COPD because I think that's going to be the best way that I have to show you. So what I'm going to do on my patients, I'm going to give them a little bit more volume because they've got a nice distendable lung. They have COPD. But now what I'm going to do, and this is not what I'd really do to a patient, this is what I'm trying to do to show you auto PEEP in my patient. So what I want you to look at here is flow. Flow goes in and then it goes out, and we come back to our zero baseline. Now what we're going to expect to see, and I hope that I can generate it, okay, is that my patient does not fully return. So you see how he doesn't fully return back to the zero baseline. I'm going to do an expiratory pause on him. And I would never do this to a real patient. I'm doing it to show you something. So you can see on that expiratory pause. Okay. So normally your expiratory pause would show that you don't come back to your baseline. You see how you don't come back to baseline there? So before the next breath begins, you should always empty your lung. Okay. Because you're not emptying your lung, your peak pressure is going to go up. Because you're not emptying your lung, your patient is going to be dysynchronous. Okay, so I'm going to go down on my flow. Actually, I'm not going to go down my flow. I'll just leave him at 60. Put him back down to 60. I'm going to put his tidal volume down. And watch what happens to his peak pressure. And then I'm going to go down on his respiratory rate. So as I've gone down on his tidal volume, his peak pressure is going to drop. Okay, but the thing that's really important, because you can see here, he does not return to zero baseline. So he takes a breath, but he doesn't get a full exhalation. He's trapping CO2. He's very well oxygenated. He's trapping CO2 here. So you're looking at that patient, you're saying, well, gosh, I'm giving him 30 breaths a minute. The problem is that you're flowing the gas too slow for him to have enough time to exhale. So first of all, I'm going to go down on his respiratory rate, and let's see what happens. Okay, so hopefully we're going to come back close to our baseline before our next breath, and indeed we did. We did another expiratory pause. Okay, so but now we're just going to come back, and I'm going to go down on his expiratory pause. I've gone down on his respiratory rate. Do you see how he comes back now to 0? He no longer has auto PEEP. His peak inspiratory pressure dropped. He no longer has auto PEEP because he comes back to the 0 baseline. Remember before, when I was breathing him faster, he couldn't get back to the 0 baseline. Okay. Now, I'm actually going to flow his gas a little bit faster because his lungs should be relatively compliant because he has COPD. So let's see what happens. You can see that now his CO2 came back to normal, and now I'm just going to flow his gas faster. And when I flow the gas faster, you can see his inspiratory time is going to, his inspiratory time should go down, and that gives him more time to empty. Okay, so a couple of things we can do: reduce your respiratory rate or increase your flow. We can never increase your flow if your peak pressures are too high. Now, your peak pressures are high here, and I could do one of three things. I could decrease your tidal volume, I could decrease your respiratory rate, or I could decrease your flow. Okay, so the first thing typically your therapist is going to want to do is decrease your tidal volume. So let's try that. Again, remember, it's a simulator, so it doesn't necessarily always work the way we want it to. Okay, so we're getting small breaths, small tidal volumes breaths, and we can see this probably was not a good decision. Okay, so now what we might do is go up on your rate and see if that's going to help you blow off your CO2. So a lot of this is yin and yang. Your therapist stands at your bedside and makes adjustments and looks at end tidal CO2 and looks at arterial sat and tries to make the best possible decision in the moment. Okay. So now what we're going to say is, we've made some adjustments. We went up on respiratory rate. We went down on tidal volume. Our minute ventilation is 7.36. That may not be adequate to get rid of the CO2 on this patient, but we might be okay with his CO2 being 50. Okay. But now we're going to say, really, tidal volume and flow are what affect peak inspiratory pressure. So watch what happens when I go down on his flow rate. Because that peak inspiratory pressure should drop significantly, and it did. It went down to 40, and I assume it's going to go down below that. Okay. Now, meanwhile, what's really important for us as nurses to appreciate is that patient's going to be agitated. He's either going to be somnolent or he's going to be agitated, and giving him sedation isn't really the point. You and your therapist should stand at the bedside, and you should take every opportunity with your respiratory therapist to watch what they're doing, to ask them to explain it. I want to remind you, when peak inspiratory pressure is high, your airways are more resistant or they're less compliant. Alveoli are really compliant. The airways are about resistance. You have to rule out all the resistance issues. Remember, mucus plug, coughing, tube is in the wrong place, you're tonguing, you're biting, you're agitated, you're breathing against the ventilator. Once you rule those things out, you now have to say, should I change the volume or should I change the flow? Now, you're not the one who's making that decision. Your therapist is going to make that decision. But the reason we do protective lung ventilation and permissive hypercapnia is when I can't get your peak pressure down, I have to go down on your tidal volume. So I'm going to go down again on tidal volume. I'm at a respiratory rate of 20. Okay, now I've reduced the tidal volume, so let's be sure we understand as the tidal volume goes down, the minute ventilation is going to go down. As the tidal volume goes down, the CO2 is going to go up. As the CO2 goes up, the pH is going to go down. But if that's what I have to do to get your peak pressure down below 40, that's what I'm going to do. Remember, pressure is always about volume and compliance or volume and resistance. If you have a lot of resistance, even a low volume will yield a high pressure. If you have so you have high resistance, low volume, high pressure. You have low compliance, low volume, you're going to have a high pressure. So we have to think outside of the box. And what's most important is to remember that CO2 removal is about tidal volume times respiratory rate, which is minute ventilation, and the amount of time you have to exhale in your cycle. Exhale time is directly related to how quickly the gas gets in to allow time for it to get out, and that is known as the I to E ratio. So again, last week and the week before, we talked about PIP, we talked about plateau, we talked about oxygenation and mean airway pressure strategies. We're talking about drive pressure as something really important, which is peep plateau minus peep. You'd always like that to be less than 15. And look at what we've achieved here. Am I going to permit you to stay a little bit up with that CO2? I am. You're a COPD lung. You're oxygenating well. I'm flowing at a level that keeps your peak inspiratory pressure down with the tidal volume that keeps your peak inspiratory pressure down. I could go up on the rate, but as I go up on the rate, I will also have to go up on the flow to make sure that you have enough time for exhalation. When I go up on the flow, my peak pressure is going to go up. So that may not be something that I can decide in that moment. All right. Now, where this is always the best is if we can actually be at the bedside and make rounds in order to really look at these strategies at the bedside. Not that I would make any of these changes at the bedside, but I just want to remind you that you should have the basic answers. When you look at your patients, are they oxygenating well? Remember, we're going to address that with PEEP and FiO2 and I time. The longer the I time, the more you recruit the lung. And we're going to measure that in the most primitive way with the P to F ratio, which we have discussed before. Is your patient removing CO2 and are we protecting their lungs? That's going to be about tidal volume, respiratory rate, i.e. minute ventilation, and flow rate, making sure that you shorten the inspiratory time to allow more time for exhalation, but you can only do that because you're going to slam that gas into the lung if the lung is compliant. And remember that we look at lung compliance in the most primitive way. We start with that peak pressure, and then we do a P plateau, which traps the gas in the lung, looking at the functional alveolar surface. I hope this has been helpful to you. The simulator I'm using is not mine. It's the X-Lung simulator. It was actually developed in Spain. It's available for anyone who wishes to purchase it. It's an annual fee. I won't share how much that is. You'll determine whether it's worth it to you or not. I thank you very much for attending today during Thanksgiving week. Tomorrow, I will also have a virtual talk talking about left ventricular assist from LVAD to ECMO. And hopefully I'll see you then. And if not, have a happy, joyous Thanksgiving. Pray for peace, pray for kindness, and embrace all persons, regardless of what their belief system is, where they reside, what color their skin is, what they choose in their life. Pray for peace and let us be thankful. Thank you very much. See you next time. Bye-bye.
Thank you.
Thank you. Bye.